Now you can keep going. Next click. Why do we do this, or why do we consider it? Next click, please. I think arterial hypertension remains a significant burden to everybody, individuals and society. Next click, please. And there's a significant number of patients in the adult population that have hypertension, and it's estimated to be about 50% by 2025. Next click, please. And more importantly, there's a significant number of patients, there's a percentage of patients that are considered to have resistant hypertension despite availability of potent medications. Next slide, please. Hence, I think it's obvious that there need to be alternative treatment options. Next slide, please. And one such treatment, obviously, for this presentation is the interruption of the renal sympathetic nervous system. Next slide, please. Let's first talk a little bit about the anatomy and physiology. Next click, please. There's an efferent component of the sympathetic nervous system, and there's an afferent component. Next click, please. And let's first focus on the efferent component. Next click, please. This shows the kidney and in the macroscopic view and microscopic view. Next click, please. And next click, please. Looking at the afferent system, there are signals that come from the cortex, limbic system, hypothalamus, and brainstem that are integrated in the brain. Next click, please. And then really down to the spinal cord. In particular, it's really down to the intermediolateral column, which is the gray substance between the anterior and posterior horn. Next click, please. And from there, presynaptic fibers exit the spinal cord. Next click, please. And make up the splanchnic nerves, which then relay at the celiac and superior mesenteric ganglia. Next click. To postsynaptic fibers. These postsynaptic fibers then course alongside the renal artery, mostly in the adventitia, to virtually every aspect of the kidney. Next click, please. Including, next click, please. You can click about 2 or 3 times to the tubular epithelial cells. Next click. To the juxtaglomerular apparatus. Next click, please. And to the renal arterioles. Next slide, please. What really happens at the microscopic level? This shows a nerve ending in yellow at the left-hand side. Next click, please. Norepinephrine is released at the nerve cell ending, and it then binds to the alpha-1b receptors of the tubular epithelial cells. Next click, please. You can keep clicking a few, actually. Just keep clicking a few. Then it binds to alpha-1b receptors, which activates. Next click, please. Next click, please. You can click about 2 or 3. It activates the sodium ATPase, sodium potassium ATPase. Next click, please. And by activating the sodium potassium ATPase, it causes sodium retention. Next click, please, which then causes blood pressure increase. Next click. You can keep going a little bit. Next. 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 Okay. Next slide, please. This shows a nerve cell ending at the adjacent to the granular cell of the juxtaglomerular apparatus, and once again norepinephrine is released. You can keep clicking a few, which binds the beta-1 receptors and via a G-protein coupled mechanism activates the adenyl cyclase, which then splits ATP into ADP and into phosphates and cyclic AMP. You can click a few ahead, please. Just keep clicking a few. That then activates the release of renin. Keep clicking. Keep clicking a few. You can keep clicking a few. So here's the activation of the adenyl cyclase. This converts ATP into phosphates into cyclic AMP. Cyclic AMP then causes release of renin. Keep clicking. Keep clicking a few. Keep going, keep going. And renin, of course, then activates the renin-angiotensin-aldosterone system. Next slide, please. Next slide. Keep clicking. You can just keep clicking. And first of all, it causes splitting of angiotensinogen into angiotensin 1, and angiotensin 1 then eventually gets converted to angiotensin 2 via the ACE. Angiotensin 2, you can keep clicking a few. Angiotensin 2 then causes vasoconstriction and also causes fluid retention via mineralocorticoid release. Of course, it can also cause ventricular hypertrophy and vascular remodeling. Keep clicking a few. Just keep clicking. There you go. Next slide, please. Now, finally, there are also nerve cell fiber endings at the arteriolar level, which causes vasoconstriction. Keep clicking a few. So norepinephrine is released, binds to the alpha-1b, alpha-1a receptors, activates the phospholipase C, which then splits phospholipids into diacylglycerol and IP3. Keep clicking a few. Just click ahead a few. Just keep going. Just click a whole bunch. This activates the phospholipase C. Here's diacylglycerol and IP3, which then causes calcium release and muscle contraction. Keep clicking a few. Keep clicking a few, that's okay. So I think the efferent component supplies every aspect of the kidney. It's very important. By actions on the tubules, arterioles, and juxtaglomerular apparatus, activation of it causes a blood pressure increase. Next slide, please. Let's look at the afferent component now. Next click, please, or click a few. Just like there are fibers that go alongside the renal artery to the kidney, there are also fibers that exit the kidney and are relayed to the spinal cord. Click a few, please. And then from the spinal cord, signals are transmitted to the brain stem and central nervous system, which activates the overall sympathetic drive. Click a few clicks, please. And as you activate the overall sympathetic drive, you will also cause a blood pressure increase. And go to the next slide, please. Good. Next slide, please. Good, good. So interruption of the renal sympathetic nervous system reduces blood pressure. Next click, please. What is the evidence? Well, there's animal data. Next click, please. And there's human data. Let's first look at some of the pivotal animal experiments. Next click, please. Keep going. This is a dog model, and this was actually published in 1916, which is quite interesting. And this was removal of the kidney from a dog model. Keep clicking a few. And then reimplantation of the same kidney into the same dog. And in the process of this, can you click a few? This actually causes significant diuresis and with it a blood pressure reduction. So if you remove the kidney from a dog model and reimplant it into the dog, you cause diuresis and blood pressure reduction. What you're really doing with removal of the kidney is you're completely separating the sympathetic nervous system of the kidney. You can click a few here. You can keep clicking a few. Okay, and likewise, if you stimulate the splanchnic nerve, which courses to the kidney, then you can cause chronic renal sympathetic nerve stimulation, which actually causes hypertension in dog model. Click the next, please. Good. Next, please. And this effect is seen despite no change in renal blood flow. Next slide, please, or next experiment. And you can click a few here. This is another experiment with the rat model. This is the spontaneously hypertensive rat, which is a breed of the Worcester-Kyoto rat, discovered to be hypertensive. Next click. Just click a few clicks. After 5 to 6 weeks, it develops hypertension, and after about 40 to 50 weeks, it develops cardiovascular disease. If you do a bilateral renal sympathectomy, you can actually attenuate or prevent the development of hypertension. Next slide, please. Let's look at some of the human data. You can click a few. Good, you can click the next one. So I think there's ample experience actually from surgery in the 1940s to 1970s with surgical sympathectomy. And what this actually showed is that there was significant blood pressure reduction with surgical sympathectomy. And in fact, not in a randomized fashion, but in an observational fashion, people actually observed mortality reduction. Of course, there were significant side effects associated with the denervation, and so this was no longer pursued after the 1970s with the advent of new antihypertensive medications. Next click, please. Next click, you can click one or two. So what does current catheter-based therapy entail? Next click, please. So sympathetic fibers are predominantly in the adventitia of the renal arteries. Next click, please. You can click a few here. You can see that the nerve fibers in the adventitia here, they're usually about 1 to 8 millimeters away from the lumen of the artery, and they're highly sensitive to heat created by ultrasound or radio frequency energy. Next click. Keep going. And this just shows, you can click a few here. This shows the guide catheter positioned in the renal artery. You can see the actual ablation catheter, which is positioned in the distal portion of the renal artery. You orient it in various different quadrants of the renal artery as you pull back, and then you apply the radiofrequency energy. You can click a few here. Good. And next, please. You can keep going. This just illustrates the burn marks within the renal artery in a circumferential manner. You can keep a few forward here. You can keep going. You can keep going. This is the actual device. So you can see the ablation catheter on the left-hand side in the upper portion. You have a handheld device where you can actually steer the distal tip. You can flex it in different directions. Then you see the console, which gives you feedback on the impedance and the drop in impedance while you're ablating. Next click, please. You can click a few here. This just shows the actual catheter in the right renal artery with an angiogram. Next click. You can keep going. Now the question is, go back one, please. So the question is, does renal denervation actually lower blood pressure? Go back one slide, please. Does it lower renal sympathetic nervous system activity? And the second question is, does it lower the overall sympathetic nervous system activity? Next slide, please. And in order to answer that, you can assess the activity of the renal sympathetic nerves before and after denervation, which really reflects the efferent sympathetic activity. And then you can measure the activity of the overall sympathetic drive, which reflects the afferent denervation. You can click the next two clicks, please, or next three clicks. The first one you can determine by renal norepinephrine spillover measurements, and the second one by overall norepinephrine spillover. Next slide, please. Then also you can look at the muscle sympathetic nervous activity, and this is really a surrogate of the overall sympathetic tone, and you can do that with microneurography. Next slide, please. And this shows the proof of concept data that was published in 2009, which shows that, next few clicks, please, which shows that the renal norepinephrine spillover was significantly decreased compared to baseline after renal denervation. These were 10 cases that were studied. And if you can click a few ahead, please. And there was significant reduction in the norepinephrine spillover here, both renal and total body norepinephrine spillover. Next slide, please. This shows a single patient also published in 2009 demonstrating, you can click a few ahead, please, demonstrating a significant blood pressure reduction after denervation compared to baseline. And also, once again, significant reductions in renal and overall spillover of norepinephrine. Also, there was significant reduction in renin release, and interestingly, the renal plasma flow increased. You can click a few ahead there. And next slide, please. And this shows the microneurography or muscle sympathetic nervous system activity. On the bottom portion of the slide, click next, please. You can see the bursts per minute before denervation on the left-hand side, and then after denervation, I think this is 30 days later. Next click, please. Just click a few clicks ahead. You can see that the burst activity reduces from 56 to 41, and then eventually at 12 months follow-up to 19 bursts per minute. Once again, a reflection of a reduced overall sympathetic nervous system activity. Next slide, please. And then, of course, there's the Simplicity 1 and 2 data. You can keep clicking ahead, please. There's Simplicity 1 and 2, and you can keep clicking ahead 1 or 2. And Simplicity 1 was the proof of concept data. Click ahead, please. Which was a non-randomized feasibility and safety trial. Next click, please. 45 patients were enrolled. Next click. You can just click a few ahead. All had resistant hypertension, and they all had, of course, bilateral single renal arteries with a minimal diameter of 4 millimeters and minimal length of 20 millimeters. Next click, please. And this shows the blood pressure reduction at 12 months, 6 months, and 1 month. You can see there was a significant blood pressure reduction of 27 over 17 at 12 months. Next click, please. You can keep clicking a few here. There you go. Good. Next slide. Okay, now this is the data excluding the 4 patients in that trial whose blood pressure regimen was intensified, and despite that, there was blood pressure reduction. Next slide, please. You can click a few ahead, please. And this is Simplicity 1 data and registry patient data, which shows that the blood pressure reduction is maintained at long term at 24 months. Next slide, please. You can click a few ahead there for the next slide. And then there's, of course, Simplicity 2, which is a randomized unblinded trial. And you can see 106 patients were enrolled. They were actually randomized 1-to-1. This is an error on the slide. And there was a catheter-based versus medical therapy in resistant hypertension. You can click a few ahead there. You can click a few ahead. Primary endpoint was systolic blood pressure at 6 months follow-up, and there was a significant, it's too fast. There was a significant difference compared to the medical treatment group and the device group of 32 or 12 millimeter mercury was a reduction in the device group, and then there was really none in the control group. Systolic blood pressure reduction of more than 10 millimeters of mercury occurred in 84% of patients, so there were about 16% that were non-responders, there was a significant reduction in ambulatory blood pressure, although it was less pronounced than the office blood pressure. Next slide, please. And so how about safety? There was one guide catheter-induced dissection requiring renal artery stenting. There was one progression of atherosclerotic plaque and one poorly remote from the radiofrequency application site. There were minor groin complications. Next slide, please. Limitations, it's obvious that Simplicity 1 was non-randomized. Simplicity 1 and 2 were unblinded, so there's a placebo effect and observer bias possible. Next slide, please. Next slide, please. And there's some other data looking at benefits both in patients with obstructive sleep apnea. There's also some data on patients with atrial fibrillation. I think there was a question earlier in the audience about atrial fibrillation and renal innervation. There's one study that looked into recurrence of atrial fibrillation after pulmonary vein isolation in patients who were ablated, who had renal sympathectomy, and those actually had less likelihood of recurrence of atrial fibrillation after pulmonary vein isolation. There's also some data on obstructive sleep apnea with some improvement in the hypopnea index. There's also some improvement in fasting glucose, insulin, C-peptide levels in one study. And there's also a study that looks into left ventricular hypertrophy and diastolic parameters with some beneficial effects. Next slide, please. So in conclusion, renal innervation has a sound physiological basis. It's a safe procedure. There's a good short and intermediate results. It's a promising additional tool in the management of hypertension and perhaps other conditions associated with increased sympathetic nervous system activity. Thank you.
Thank you very much, Dr. Stephen. Both your presentations have been very informative, and I'm sure there'll be a lot of questions, but because of paucity of time, maybe we'll allow one or two questions to set the ball rolling. May I ask you, what is the success and failure rates with the Watchman device?
What is the success rate again?
And the failure rates, success rate or the failure rate with the Watchman device?
You mean procedural?
The procedural success rate.
Yes. I think in terms of, if you define a procedural success as delivery of the device into the left atrial appendage, I think currently, and that also was shown in PROTECT-AF and in PREVAIL, it's certainly above 90%, maybe 95, 98%. But if you look into questions such as residual leak as an example, so if you look at residual leak rate, you'll find that even if you implant the device successfully, there are significant residual leak rates with the Watchman device. So, after implantation, you'll find about 40% with some residual leak, but usually it's small, and about 8% that'll have a residual leak more than 5%. So if you define success as placement of the device with no significant residual leak, then the success rate probably is a bit lower than 90%. Does it answer the question?
Yeah. Regarding resistant hypertension, do you think that ambulatory blood pressure monitoring is mandatory before you take up this patient for denervation? Should be.
Yes. I personally believe that we're treating a silent disease. People are not symptomatic typically until they have a stroke or another endpoint. And so we have to be very, very careful that we do the procedure really for people who definitely need it. And so I would say that before doing a denervation, I think everybody should have ambulatory blood pressure, because there are some patients that do have what we call white coat hypertension, who in fact have fairly acceptable blood pressure levels at home in an ambulatory setting. And so I believe that patients do warrant an ambulatory blood pressure recording prior to renal denervation.
What do you think radiofrequency ablation is, as far as comparison between ultrasound versus radiofrequency ablation? Which one of these two strategies is superior? Ultrasound superior or radiofrequency ablation superior?
Yes. I don't know the answer to the question, because we don't have the same amount of data on ultrasound application compared to radiofrequency application. You're talking about devices such as the Record device as an example. I think the preliminary data that we have show that there also is a comparable blood pressure reduction with ultrasound application. And so if you ask me, my intuition would say that probably any type of energy that you apply to the sympathetic nerves is effective. It just depends on what dose or what regimen you use. And but we do have to wait for further results looking at ultrasound devices to make sure that those actually do have the same effect as radiofrequency energy.
Is it necessary to check the norepinephrine level before considering radiofrequency ablation?
Yes, I think I would not recommend this, because the problem with checking serum or plasma norepinephrine level is that it doesn't really reflect what's going on at the nerve terminal. The actual plasma level is dependent on so many other factors that I think it's really more important what norepinephrine concentrations we have at the nerve ending. Optimally, I believe that if we had a way to measure the whole body norepinephrine spillover in a very easy way, then this should be measured prior to renal denervation. But the problem is doing this measurement is very tedious and requires a lot of hoops and a lot of expertise to do. And so I think using that technique as for an everyday patient is not going to be feasible.
Do you have non-responders to this treatment? Non-responders?
Yes, absolutely. It's, in Simplicity trial, the non-responder rate was about, I think it was 16%. And that sort of reflects as to what we see in our practice, that the non-responder rate is about 20%. I wish we knew better ahead of time which patients would be non-responders and which wouldn't. And groups are looking into that. We're looking into various different patient groups, such as elderly patients, patients with accessory renal arteries, patients with or without diabetes, to determine what really predicts response rate and what doesn't. But I think there is nothing yet that we can conclusively say to determine which patient is going to respond and which one will not.
This question is regarding the Watchman device. How do you follow up these patients as far as the anticoagulation status is concerned?
Yes. I think the anticoagulation is somewhat controversial, and it varies by the center. But if you go by the Protect-AF trial, which I would recommend, then you would have to anticoagulate the patient for 6 weeks with warfarin and at least a baby aspirin. And after that, you complete a total of another 4 months of aspirin and Plavix after you stop warfarin. And I would definitely recommend that, and then lifelong aspirin if you can. However, there's some data, for instance, from the ASAP registry that patients can undergo safe Watchman implantation even in the absence of oral anticoagulation, so just with aspirin and Plavix. So certainly, if you have a patient with a very, very high bleeding risk, it might not be unreasonable to implant the device in the absence of warfarin, but using aspirin and Plavix. Now, I think it's very important that one uses a TEE follow-up in any patient, whether warfarin or not, or whether what regimen you use, because you do find occasional device-associated thrombi. So, for instance, in the Protect-AF trial, the thrombus rate was about, I think it was 4%. So it's not negligible. So it's very important to repeat TEEs at least at a 6 months basis, maybe even at a 1 and 6 months basis, just to make sure that you don't have thrombus formation, particularly in the vulnerable period when the device hasn't endothelialized yet.
Dr. Stephen, how do you judge that the denervation is complete? One, how long will it take to know whether the response is full? And can you repeat it and after how many weeks?
Mm-hmm. So how do you know whether it's complete? Unfortunately, the answer is we don't know currently whether it's complete after the procedure, because you do not observe an immediate blood pressure reduction typically. And And of course, there are so many other factors in play, such as sedation and analgesia, that you don't really know whether the blood pressure reduction, if it occurs, is related to the denervation or not. So I think currently you have no measure of really knowing. And the second part of the question was, can you repeat that, please?
Second part, I said, how long you will wait to know whether the blood pressure response is coming or not? In case the blood pressure is not going down, when can you repeat the procedure once again?
Yes, there are actually, I think one should say that if even after 1 month, that's not enough. You know, if after 6 months there's no blood pressure reduction, you can still wait to 12 months, and you'll find some patients who at 12 months, respond with a blood pressure reduction. And so I think I would not make a conclusion too early after denervation. And then the next question that you had was, is it possible to re-denervate a patient? And I think that's certainly a possibility if you have a patient who despite denervation remains significantly hypertensive and has no other option. I think a second denervation certainly could be done. The success rate of that we currently do not know, because there are not enough patients available that were studied yet in order to make any conclusions.
Thank you. What are the antihypertensive you would like to avoid in such a situation? I'm repeating my question.
I think there's really no one antihypertensive that I would avoid generally. I think it's more important to really be sure that before you embark into denervation that you really try every agent that you possibly have, including spironolactone or eplerenone, which are the mineralocorticoid antagonists, before really being sure that the patient actually is resistant. But in terms of the procedure and safely doing it, I think there's really not one medication that has to be stopped in order to do the procedure. With the exception, perhaps, I mean, here we don't have this medication anymore, but if there's any country that still has moxonidine is a sympathetic inhibitor. That medication, obviously, I would not use because it's a very strong, very potent overall sympathetic inhibitor. But I think this is no longer produced in any or used in any country.
Is there a late catch-up phenomena, like after 1 or 2 years you may have renervation and again a rise of blood pressure?
There are some where you can see that, but I think the data that we do have that goes out to about 2 years shows that there is a response rate that, if anything, actually gets better over time. But certainly you can find a patient that will have an increase in blood pressure again. If that occurs, though, I would like to stress this point, is that if you have a patient who was denervated, who had a nice response, and then all of a sudden has a significant increase in blood pressure again, I would very much urge to undergo imaging procedure for the renal arteries, because renal artery stenosis does occur. It's been reported. There's no doubt about it, and I think it occurs regardless of what kind of energy you use, whether it's ultrasound or radiofrequency energy. You will have a risk of renal artery stenosis, and so a patient who responds and then has a high blood pressure once again, I think you definitely have to exclude renal artery stenosis.
How many lesions you give in each renal artery?
Yeah. Typically, it depends on the size and the length of the artery, but I would say that between 4 and 8 ablations would be my goal, and I try to do more than less. So I think the average that I would do is about 7 or 8 ablations. If you have a renal artery that doesn't allow you to do that, then obviously you have to go with less ablations, and this really accounts for the simplicity catheter. If you take say one of the other devices that are now available, including the Bessix device or the Recor device, those are of course devices where just one ablation might suffice.
What is the wattage of your RF energy?
I'm sorry.
What joule?
Oh, the wattage, it's 8 watt.
8 watt.
Yeah, so it's considerably lower than what you would use, for instance, for atrial fibrillation procedures. I think they use quite a bit higher wattage, and so, but nevertheless, there are studies to look at the histology in animal models after ablation, and there's no doubt that you can find some fibrosis in the media and adventitia, and like I said, there have been reports of renal artery stenosis. Luckily, at this point in time, those reports are fairly limited, but I still would say that that's something you definitely would have to follow up on.
Okay, Dr. Bertok, it has been very nice talks, both the nice. We have many more questions, but because of paucity of time, and Dr. Tinto has another presentation, so we'll stop here, and maybe next year we see you in India.
Yes, I wish I would be there. I wish I could also do the presentation live, because I noticed that with clicking, it's a bit difficult to click the slides. But I hope you had fun watching the presentation.
Yeah, it was a great experience. Thank you very much.